Hey everybody, this is John Oxley from Huntington Physical Therapy doing my Friday tip of the week. You may have noticed that we didn't do a Friday tip of the week last week. I was going to do it with Dr. Nolte here, who is a childhood friend of mine. He's a neurologist at Cabell Huntington Hospital. We both had, I was sick, he had another issue come up, so we weren't able to do it last week, so we are making it happen this week. What I wanted to do is kind of piggyback on the interview I did with Alicia last week on Parkinson's. Justin, or Dr. Nolte, sees patients, at the beginning of kind of their Parkinson's journey. So I wanted to ask him some questions about that. So really happy to have him doing this. So first question, I guess, is how do you guys diagnose Parkinson's as a neurologist?
So Parkinson's is a diagnosis based on a constellation of physical symptoms. Most patients will have one or all of these features. Typically there's a slowness of movement. There's a tremor that's present at rest. Many people have a tremor with action, but this is one that when you're sitting still seems to be more prominent. There's a general difficulty with ambulation. A lot of times there's a shuffling gait which can lead to falls, or a sense as if somebody is falling forward. Based on patients presenting with those symptoms, usually we'll get a referral and we'll examine them and kind of go from there.
So there's not just one like blood test or MRI or CT scan or anything that says, yes, you have Parkinson's?
No, correct. There is a specific imaging modality that we get that can help confirm the diagnosis, but it's typically made clinically based on somebody's appearance and based on their exam and their history.
Well, and the patients we get with Parkinson's tend to have a lot of kind of anxiety about seeing the neurologist and going to see the doctor, kind of that white coat syndrome. They're afraid something's going on. Can you kind of describe to people what their first appointment would be like with you at Cabell Huntington?
Sure. People with Parkinson's disease, because it is we say neurodegenerative disease, which means a condition that will progressively get worse over time. When people hear that term, they automatically assume the worst. They're not sure there's anything to be done. Many people see a loved one or a friend who has bad Parkinson's disease and feel like that's where they're going to be in the very near future. So there is a lot of early anxiety. The first visit is really just data collection examination. So it'll be a little bit longer than your subsequent visits. The examination for someone with movement disorder, Parkinson's disease, is usually a little bit more detailed. But it's a lot of history. We go through medications, review any imaging that's done. If it's clear that that's the diagnosis, we may consider some treatment options. If it's unclear, then we may hold off on treatment and get some more testing, whether it's imaging or look at some other medications before we jump to treatment at that point.
So now we were talking before we came on video. So there are some drugs and potential strokes that can seem like Parkinson's. So how does that work? Can you describe that a little bit?
Yeah, so Parkinsonism means patients who present with Parkinson's-like symptoms. So they have the tremor, they have the shuffling gait, they have the unstable sort of ambulation, the postural issues. And that's typically experienced on both sides of the body. People with idiopathic Parkinson's or the neurodegenerative version of Parkinson's disease due to a lack of a neurotransmitter is usually one side or the other. Common medications that we see cause a Parkinson's-like condition are the nausea medicines, so Phenergan, Zofran, Compazine, things like that, as well as some of the antipsychotics like Haldol, Risperdal, Seroquel. And until patients are off those medicines for upwards of 6 months, we don't ever know for sure if it's all medication related or if it's actually the neurodegenerative Parkinson's disease. Probably what I see more often than not as a stroke neurologist is the vascular Parkinsonism, which means you accumulate these small areas of stroke over time, which leads to a slowness of thinking, a slowness of movement, a shuffling gait, the tremor. And the drug-induced or stroke-induced Parkinson's symptoms may be amenable to the medical therapy, but not always. But those conditions, you can either remove the medication or you keep the patient from having any strokes, then they should not have that subsequent decline. Whereas the Parkinson's disease related to the neurotransmitter deficiency is one that actually gets worse. So it's important to figure that out early on to outline a prognosis.
Well, and that's something that you guys could do in the office as part of your
usually the initial history, again, we look at the medications, we'll look at any imaging that's been done to try and figure that out. If there's no offending medications, if the imaging is not suggestive, then we tend to lean more towards this idiopathic Parkinson's disease and kind of go from there.
That's good info. So what are the advantages? Somebody, they start to notice a loved one with these issues, some of these kind of signs and symptoms. Is there advantages to coming to the doctor early?
Sure. The probably two biggest issues that we see from a subsequent medical condition from Parkinson's disease are going to be falls. And the majority of these patients are going to be older, and with falls come long bone fractures or other issues that can potentially alter the course of life significantly. We also see a lot of troubles with speech and swelling, so you may have some issues with things like aspiration pneumonias or respiratory issues. The sooner we can identify the condition, usually the more easily it's going to be able to be treated with the medications with the least amount of side effects. There's varying types of medications we can use, and as we escalate treatment, the potential for side effects might go up. So intervening early with minimal symptoms, obviously we're going to be able to control those symptoms better, and perhaps most importantly, we'll be able to prevent things like falls and other medical complications because of the Parkinson's disease itself.
And certainly we see from a physical therapy standpoint, the earlier we're able to get people doing this prescribed exercise program, sort of the faster and better and longer they can keep their quality of life and their movements, for sure.
And you look at endurance as well. These people who have advanced Parkinsonism or Parkinson's, by the time they come to you, if they've lost significant muscle tone or muscle bulk, it's hard to really build that back up because they don't have the endurance or the stamina to be able to really push. So you can not only improve their current symptomatology, but you can also work on baseline. So as they continue to decline, the decline won't be so steep, if that makes sense.
So basically, early treatment is something that you guys absolutely advocate.
Always.
How often, if I've got a Parkinson's diagnosis, how often do I have to come see you? Not that you're not a great guy, I would love to see you, but how often do they come?
So when I first see somebody, if we feel pretty confident with the diagnosis, I usually will initiate a medication, usually 3 times a day, and then I like to give patients 2 or 3 weeks at home to figure out how they're responding to that medicine. And I'll actually bring you back to my clinic without the medicine on board. We'll do an exam, I'll videotape you, I'll give you a medicine, I'll send you out for lunch, I'll bring you back, and then I'll re-videotape you, and then we can sit down and look at the before and after effect. These medications for Parkinson's will work within 20 or 30 minutes, so you see a very clear response very early on. Once we get your symptoms well controlled, the patient's satisfied, I may not be able to take away all tremor, or you may not be running a marathon, but if your quality of life isn't impaired with your symptoms and you're tolerating the medicines, then usually every 3 to 4 months or so, and if people remain stable, you can space it out more. These folks probably need to be seen at least 3 or 4 times a year just to maintain. Obviously, we tinker with medicines a little bit, and then in the interim, they'll be followed with physical therapy really to help maintain, if not actually build upon sort of the progress they're getting from the medications.
Okay. Now, how does Parkinson's usually progress? How do patients usually worsen?
So the problem with Parkinson's disease is that there's sort of a spectrum of disease. So there's some patients who have Parkinson's who may progress very slowly, others who may progress very rapidly. It seems that the earlier onset, there are some patients who get Parkinson's in their teenage years. They tend to do very, very poorly. It's a very rapid progression. But certainly anything that we can do to intervene early and maintain or build endurance so that with the decline coming, it's not as rapid. Is sort of probably the key there. Typically there is a timeline in which we'll try one medicine, it'll work for a while, and we'll switch to a second medicine, and then eventually perhaps a third or an additive medicine. At some point we start to run into side effects of those medicines, and that's when the surgical options for Parkinson's disease come into play. Certain patients whose memory are intact, who respond to a certain type of medication, but may not be responding as well as they used to, could be candidates after a couple further tests of actually seeing a neurosurgeon and having a brain stimulator placed.
Okay.
In some of those patients, you can actually have some of the oral medicine removed, and actually the response is actually quite amazing. It's one of the things that really got me into neurology, was seeing someone whose stimulator was off and they were devastated and turned on, and literally 10 seconds later they looked almost normal.
That's fascinating. I've seen some videos, yeah. So last question. Patients ask us this. I'm sure they ask you, are they going to die from Parkinson's?
Absolutely. Well, they're going to die. They're not going to die of Parkinson's necessarily. With Parkinson's disease, usually there's some degree of cognitive issues. Again, the biggest risks with Parkinson's, as far as potentially Parkinson's leading to your death, would be falls, and having head bleeds or long bone fractures and complications from that, or aspiration. Parkinson's tends to affect people's speech, so first it becomes kind of soft, and you can have some issues with swallowing as well. So if you're identified early, we treat you appropriately, you get the appropriate kind of supportive care, then our goal is to try to minimize the risk of those things. And eventually some people may become so impaired, don't respond to medicine, that they need to be, in a 24/7 sort of supervised role. And at that point, we can minimize that risk. But, people usually die with Parkinson's disease, not die because of Parkinson's disease, if that makes sense.
Okay. Dr. Nolte, thank you. That was really informative. Hopefully you guys that have watched this enjoyed it. If you have any questions or comments, you can shoot us a message over on Facebook. Dr. Nolte's at Cabell Huntington Hospital. If you want to send him a question or call his office for further treatment. Thanks, and we'll see you next week.